Hey, Rachel. How you going?
Okay, thank you. Just, trying to stay motivated and focused, which is hard after a long run, but
Yeah.
okay.
This is definitely I found this one of the hardest times ever going through this exam.
Yeah, I feel like that too. And I'm just really tired. I feel like it's been on a long time, but that's okay.
I want to reassure you that that's the right thing to say. If you're tired, you're studying about the right amount. Then.
Yeah, okay. Awesome.
I think someone told me a bit depressingly that, if you're sleep deprived, if you're a little bit depressed, if your family and friends don't know where you are, that's about the right level of study. That just seems really unhealthy. But I'm there.
Yeah. Okay. I'm nailing it then.
You're nailing it. Yeah.
It's pretty accurate.
Well done, Rachel. Yeah. Hi, everyone, and welcome to ABCs of Anaesthesia. Again, another special episode where I've got Rachel here all the way from New Zealand, who we're doing this episode as a viva practice, and we're going to, put this up on the podcast, ABCs of Anaesthesia, as well as the YouTube channel, just to hopefully help anyone going through this exam, or hopefully just to get some interesting case discussions with an anaesthetic twist to it. Welcome, and welcome, Rachel. Thanks so much for joining me here. Tell us a bit about yourself.
So my name's Rachel. I am in my final year of advanced training. I'm based in Auckland in New Zealand, and and I'm in the midst of doing this exam in a few weeks' time.
Yeah, nice one. How long have you been studying for?
So I started studying for part 2 about a year. Probably about a year out. I probably started end of May, June last year. Yeah.
And you find that a lot of people do say the anaesthetic exams are some of the toughest exams because it's not like you study for 3 months or 6 months like other specialties. You end up studying for a full 12 months, which is, I don't know, I feel like that's an incredible amount of work.
Definitely. It's been a long time. I've definitely felt like it's needed to be a marathon and not a sprint for this exam. So
yeah, it almost changes your DNA as well. Like after this exam, you'll have so much time. And like, what was I doing with my time if I wasn't in the study? That's a bit depressing. Oh, well, good. Well, welcome, and we might as well get started. I've just put in the chat here the case, just so you've got it there. I'll get you to in the viva itself. There's a stem, and you read that for 2 minutes. You take some notes if you want, and at the end of that, 1 to 2 minutes, I guess, we'll have a discussion about the case. This is for everyone: a 50-year-old male, 80 kilograms. He presents for your ENT list for a biopsy, plus or minus removal of this vocal cord tumour. And I'll give you 2 minutes, and you'll also have this picture with you. Can you see that? That's the gentleman there in question.
Okay.
Wonderful.
Yeah.
Is that enough time there, Rachel?
Yeah, that's fine.
Okay. Just quickly, can you hear my mic okay?
I can. Yeah, I can hear well.
Excellent. Now, what I might actually do, Rachel, so that's about 2 minutes. What did you write in those 2 minutes?
So in the 2 minutes, I wrote what I thought an opening stem for me would be for this question. And I don't know what the opening question is going to be, but I thought a bit about how I would assess this patient and a bit about intra-op management of that patient. But on my paper, I wrote about assessment and I wrote about an opening stem.
Fantastic. And that was my fault. The question was actually, what specifics would you like to know on assessment? So great.
Okay.
Great.
Cool.
So why don't we go ahead? What specifics, Rachel, would you like to know on assessment?
Okay, so this man is having elective but urgent surgery for cancer. He's got possibly a high BMI, and this is surgery that involves his airway. So on assessment, I would like to take a history, do an examination, and look at a few investigations. On history, I'd particularly want to know a bit more about what they think this lesion is, if it's cancerous, if he's having any other effects from that, any metastatic disease. I'd like to know about local changes from this lesion. Has he got any voice changes? Does he get any shortness of breath on exertion? What's his functional status? And does he get any obstructive symptoms? And do those change if he sits up, lies down with activity, etc. I'll then like to know a bit about his other past medical history. Does he smoke? Does he have any other significant disease? Has he had a previous anaesthetic, and has he ever had a problem with an anaesthetic? That would be the key features in addition to my normal history.
Which other diseases are you most worried about, or which?
So this is a vocal cord lesion. So my concern is that he might be a smoker and may have respiratory disease. And I'd want to screen him for alcohol and potential sequelae of that as well.
Sounds good. Keep going.
All right. On examination, I would like to do a full and thorough airway assessment. I note from that photo he looks like he's got a high BMI and he has a beard, so it could be potentially difficult bag mask ventilation. I'd like to know about his dentition, his mouth opening, thyromental distance, his neck movement. I would like a full set of obs. I'd like to examine his chest, listening for any air entry issues, wheeze. I'd like to know whether he has any stride or at rest in the bed space, and also by lying flat. And looking at investigations, I'd particularly like to know if they've done an Nasendoscopy and what that showed.
Fantastic. Look, so I'm going to give you the Nasendoscopy findings, which look like that.
Okay.
What do you see there?
So there's a single isolated lesion on the anterior aspect of one of his vocal cords.
Fantastic. Good.
View of his glottis.
So I just want to give you some feedback. I really like your assessment there. It was really sharp and you hit so many of the high points. So I just want to, I guess, go into a bit more detail. You know, you've got a lesion, you want to know the diagnosis. You mentioned it straight away. You want to know the effects of the mass. And I always talk about mass effect on critical, or mass effect will affect organs for their organ function. So if this was a pancreatic tumor, you'd have pancreatic issues. But then for this is airway. So you're even more concerned because now this is a critical structure. Pancreas doesn't, you know, it's not life or death immediately. Airway is life or death. And you mentioned exactly what I want you to mention, which was, you know, what are the effects of that mass on the airway, any symptoms, stride or obstruction. And then if it's positional, because we really care about positional in any critical structure mass effect lesion. And then you talked about all these other useful things around that, because you actually went through then the cause of that, and you then extrapolate, well, I'm worried about smoking as a risk factor, therefore I'm worried about COPD. That's a really great way of going, there's my problem, what caused it, and what are the complications as well. So I really liked your format because it covered so many things. The one extra thing I add in my history is rapidity of progression of any tumor, but that's, you know, a small point. Then you did a thorough assessment and mentioned the things very quickly. Again, you're going through this very quickly, which, you know, you're just getting marks on the fly very quickly. Tell me about all the elements of your airway exam again. So
I would want to examine him for basically ease of bag mask ventilation, LMA insertion, endotracheal intubation, and front of neck access. So I wanted to know about his beard, which I've seen. He's got a large neck, which I've seen. I'd like to know about his mouth opening, his dentition, what his Mellon-Party score is, what his thyromental distance is, whether he has good or poor neck extension. Yeah.
Anything else? No, that's all right. The one thing I add extra is jaw protrusion, but you covered it well.
Protrusion, yeah.
Fantastic. Yep. So let's say he's got the beard. His weight is, so he's 80 kilos and his height is about 180 centimeters. So his BMI is not too bad. And his airway exam is actually all normal except for the beard. So Mellon-Party 1, thyromental greater than 7 centimeters, mouth opening good 5 centimeters. His jaw protrusion, however, is B, so his teeth are in line. That's probably the only thing that's an issue. The Nasendoscopy you saw. Do you want any other investigations for this case?
The only things I'd probably like to know if he's on any other medications,
he's on
renal function, full blood count would be routine screening, but not specific.
All of those were normal, and like you said, yeah, because it's just a small tumor, you don't need the CT scan. It's not one of those cases, and you're not worried about METs according to the treating team and oncologist. Good. So knowing everything you've got now, what's your plan for this airway?
So my plan for his airway would depend on what the surgical plan is going to be and what they're planning to do, whether they want him in suspension laryngoscopy, whether they're planning to use lasers, and what access they want to this and the tube size that they'd be happy for me to use.
They're happy with a smaller tube, and they're potentially going to use laser. Yeah, there's no other need for like kind of an open technique like a suspension laryngoscope. So what do you reckon?
So for this, then my plan would be to do a general anaesthetic. I personally would use Viva with remifentanil. I would use a laser resistant tube, size 5 to, well, probably a size 6 in this gentleman. and I would intubate him using propofol, Remy, a large dose of rocuronium to minimise bag mask ventilation time, because that's what I predict is difficult. And I would intubate him traditionally using a direct laryngoscopy and a MAC 4 blade.
Fantastic. So just to give you feedback on that's exactly what I would say as well. My plan for the airway depends on what the surgeons need, whether there's laser, and my airway assessment. And this was a modification of an old viva that was given before I sat my exam back in 2012. And it's funny how things have changed. People do handle this question a lot better, because in the exam, you get into this mindset of, oh, wow, there's a beard. Oh dear, this could be bad. But really, this is a guy, I always say, just imagine that this is a guy, without a beard who's got a beard now. So a guy without a beard with a beard. And would you ever manage this patient any differently? So back in the day, lots of people would go through an awake fiber optic thinking that was the right thing to do. But in realism, we never changed that plan just based on the beard itself. So that was great. You went, and you also targeted the fact that I think the bag mask is going to be difficult. So I'm going to give rocuronium, as you mentioned, to get a fast intubating condition so I don't have to bag mask. And not for aspiration risk, just because bag masking will be difficult. So I thought that was really, really great. Moving on, what are your main concerns with the specific operation?
So my key concerns here are that it is airway surgery. So we have a shared airway procedure. There needs to be key communication between the surgeon and myself. We're using a laser, which has been talked about. So again, care with oxygen delivery, and need to be careful that there's no damage to the cuffs on the tube. Other key concerns are, we've talked about the concern about bag mask ventilation, and that's relevant at the end of the procedure as well, at extubation, and thoughts about bleeding into the airway.
Excellent. You may have mentioned this, sorry. And what are your specific concerns with laser?
So concerns with laser are safety to the patient, safety to the staff in the room, and potential damage to the cuffs on the tube, which can lead to airway fire.
That sounds good. How do you prepare and mitigate for these risks?
So in terms of laser safety, in our hospital, we have quite a thorough system in place. There's a laser safety nurse officer who manages the room, manages the laser itself. There's signs on the outside of the door. The staff are wearing the appropriate PPE and laser goggles, and there's very clear communication about when the laser's on and off, and when you can and can't enter and exit the room. In terms of protecting the patient, we use laser-resistant tube, which I've mentioned. There is always prepared on the table a bucket of water in case of airway fire, and the laser tube that we've selected is also protective because it helps deflect laser beam to minimise the risk of fire. It protects the source of oxygen, and it has a double cuff as well to help identify any damage to those cuffs.
Anything else?
Protecting from laser. That's all I can think of at the moment.
That's good. I like your framework. You said patient and I think staff as well. And what do I think of? And you also mentioned protocols. Patient, staff, and system protocols is a great way to organize this. I've just got a few extra things, but I don't think it's a big deal. I'm not giving you so many extra marks to them. So, wet gauze on the eyes, matte instruments, and you mentioned mostly, and low FiO2 potentially as well.
Yeah.
Good. What is required for an airway fire to occur?
So any fire needs an ignition source. It needs an oxidizer, so nitrous oxide or oxygen, and it needs a fuel, so something to burn.
Fantastic. Now, can you describe that laser safe tube? What does it look? You mentioned a few things already, but just describe it again.
So it's a long stainless steel corrugated flexible endotracheal tube that has two cuffs.
Yeah, good. Okay. That's a pretty succinct definition. Excellent. Generally speaking, what are your airway options for airway surgery?
So when I think about airway surgery, I think about whether, firstly, it's able to be performed with a modified endotracheal tube, such as a laser tube or a microlaryngoscopy tube. If that's going to impede the surgical view, then I would consider jet ventilation, which can either be performed supraglottically, subglottically, or transtracheally. And I think they're the key options for airway management.
And you mentioned that thing about, this is a balance between surgical access and being able to see the site, which is great with open techniques, and then closed techniques like tubes, which we're familiar with, but they don't give as much. They don't give as much access and vision for the surgeons. So, what are the advantages of these closed systems for us?
So the closed system, such as a microlaryngoscopy or a Laserflex tube, is that we have controlled ventilation with cuffs that are protecting the airway, that we can ventilate down, suction through, monitor CO2, monitor inspired and expired oxygen, and you can deliver volatile anaesthetic if that's your anaesthetic of choice. Disadvantages are that there's risk of rupture. Sorry, I don't think you asked for disadvantages. Rupture to the tubes and surgical access can be impaired.
Yeah, that sounds fine. Good. What are your options? Have you heard of any of these open technique tubes or devices?
Yeah, so again, it depends on where the lesion is and where the surgeons are wanting to work. So you can either use a tube that's attached directly to the bronchoscope for supraglottic techniques. You can use a hunsaker tube for subglottic techniques. And there's also transtracheal, which is not routinely used unless in a crisis, usually in my institution. Yeah.
Sounds good. Have you used a hunsaker before?
I have, yeah. I have.
What does it look like?
So a hunsaker is a relatively short, thin tube with almost a parachute thing on the end. So there's like a basket at the end that opens up, and that helps secure it to the inside of the wall. So it's quite a thin tube that you ventilate through subglottically.
Yeah, sounds good. And they used to have the benjet tubes. I think the hunsaker is an extra CO2 entitled kind of trace as well. Excellent.
Yeah.
Let's say you're getting through the surgery and the surgeon says there's an airway fire. What do you do?
So this is a crisis. The thing I would do first off is I would disconnect. Sorry, am I using this Laserflex tube at this time?
Yes, you're using the Laserflex tube. Yeah.
So the first thing I'd do is I'd disconnect my circuit because I'd want to reduce the oxygen going to the patient. So I would disconnect my circuit. I would ask someone to ring the buzzer for help, and I would ask the surgeon to stop what they're doing. We would remove the tube, flood the area with water, which is immediately available on the nurse's scrub trolley, and then post that I would then work on reoxygenating, making sure the flames are exhausted, reoxygenating the patient, assessing the airway, and making a plan to re-intubate the patient in the first instance.
Keep going.
All right. So if I was happy the fire was out, and everyone in the room was safe and there was no flames or concerns anywhere else, I would then want to, with a video laryngoscope ideally, I'd look at the cords and look at the airway, and I would want to re-intubate this patient if there was any signs of upper airway, glottic or subglottic, burns, edema or scarring. Once I'd done this, I would then ventilate the patient with lung protective ventilation strategies. I would keep them asleep with the TIVA and with TIVA anaesthetic, and I would want to discuss them with ICU so they could go there post-operatively for a period of monitoring to assess for any airway swelling and a safe planned extubation.
Do you do any other techniques to monitor for damage? Any other?
Yeah, sorry, yes. So once I'd secured the airway, we could perform a bronchoscope down and look for damage further down.
Great. Let's say that all goes well. So you've treated the airway fire, and like with most scenarios, we're just going to keep going from bad to worse. But now the patient was in ICU overnight. Everything is resolved from that. The surgeons have told you that it is probably a more extensive dissection, but they found more nodules all around the pharyngeal and laryngeal area. So now they're treated, they're safe on the ward the next night, but then at 11 p.m. this next night, you're on call at home, which is about 10 minutes drive away. You receive a phone call from the nurse in quite a bit of distress, saying that the patient has SATs of 40% and there's a lot of bleeding from the airway. You know that this is a small hospital, and the ICU reg, who's probably about 3 or 4 years as a doctor, is the most senior doctor on. There's not much other help around. What do you do?
Okay, so the first thing I would do is I would ask the nurse who was around with her. Had she called a code to get immediate bedside senior medical
help? Code has been called. There's lots of people around, but really there's just that one fourth-year ICU reg and not many others.
And can I just clarify, is this patient still intubated?
No. So they're extubated on the ward.
Okay. All right. So the priorities here that I would be getting in my car to be en route to help attend this crisis. And whilst I was en route, I'd be providing advice to them to provide 100% oxygen to the patient. I would ask that they put the patient slightly head down.
Let's say you you ask the nurse to go on speakerphone so that you can speak to everyone in the room, but specifically the ICU reg. Yeah,
Okay.
what do you tell the ICU reg who's in a bit of a panic with everyone else?
Okay, so I'd be saying to the registrar, the key here is we need to intubate this patient and recommence oxygenation and ventilation. So I would ask them to put the patient's bed head down. I would ask them to get a video laryngoscope, and I would ask them to attempt to intubate orally using a video laryngoscope.
They don't have a video laryngoscope on the ward, and they can't seem to find one because no one's around to know this. There's a lot of blood in the airway. And did you mean head down or flat?
So I would actually, if there's blood in the airway, I would want them to be slightly head down so it's draining out of the airway. I acknowledge this may make the view more difficult, but it's going to help prevent issues with hypoxia later with blood further down the bronchial tree. Okay. Yeah. So I would ask them to suction. Is there a direct laryngoscopy?
There is a laryngoscope, and the ICU reg is having a look at. I can't see anything. There's blood everywhere, and the suction isn't working well enough to fix this.
Okay. All right. So this sounds like this isn't working, and I would then, as per the vortex, I would suggest that we then try an LMA. But I suspect with that amount of blood, that's going to be unlikely to work as well. But I would ask them to try that. They
give you an LMA. The reg is like, I've put one of these in once. I'll give it a go. He tries to put it in, but there's no ventilation possible.
Okay, and he's unable to face mask ventilate with a Goodell.
Yeah. He says he's trying with a Goodell. He couldn't do it either.
All right. So at this juncture, we can't ventilate this patient, and with those three modalities, and the priority is oxygenation. So I would suggest that they perform a Scalpel Bougie tube front of neck access technique.
They haven't done this before. What do you want to say to them?
So I would ask them to grab the Kaiko kit if they have one, which should be on their difficult airway trolley. So they'll need a size 10 blade, a Bougie, and a size 6 endotracheal tube.
They can get those things. They don't have any kit or difficult airway trolley, but they can get those three things.
Okay, all right. I would ask the patient, the reg, if they were right-handed, to stand on the left-hand side of the patient.
Yes.
Yeah, and I would ask him to, using a laryngeal handshake, to feel the patient's larynx, run his finger down the midline and feel for the cricothyroid membrane.
You can feel the larynx, and you can feel a gap there.
A gap there, great. So I'd ask him to leave his finger there, take the scalpel, do a vertical incision, sorry, a horizontal incision there. And once he feels that pop, to rotate the blade 90 degrees, push it away from him so there's a gap in front of the blade. I'll then ask him to insert the Bougie, and he should be able to feel the tracheal rings as he inserts the Bougie. I'd ask him to insert it as far as he feels, maybe 10 centimetres, which is probably too far. Ask him to take the blade out, ask an assistant to railroad the tube over while he doesn't let go of the Bougie. Once the Bougie is at the front of the neck, I'd ask him to insert it by rotating it so it slowly advances into the trachea, and tell him to advance it only so the cuff is just past the skin, about 1.5 centimetres. Then ask him to take the Bougie out, to not let go of the tube, connect the mask up to the tube, and see if he can ventilate the patient.
Fantastic.
The cuff needs to be inflated after that, but yeah.
You managed to ventilate the patient, the SATs recover, and the patient survives. Well done.
Right.
How did you feel? That's the end.
Okay. Yeah, I felt okay.
Good.
Yeah, there's always little things I'm thinking about and feeling like I'm not being concise enough, but
I think you did really well. So just to go back through the airway fire, again, you handled that really well because you literally just went through the steps. I mean, for a lot of people listening, like a lot of these things, we just drill over and over again. Cease the oxygen, remove the thing that's actually flammable, douse with water. And it's often a bit of a conundrum for some trainees, but like, okay, I'm taking the airway out now. I don't have an airway, but I need to get rid of the fire. And you handled that really well. You said, look, I've got to sort out this fire first, get rid of that, and then deal with oxygenation. And, the SATs might drop to whatever they drop to, but you've got no other choice. I've just got to get rid of this fire, douse the fire, and then reinsert whatever devices to oxygenate. So I think you handle that without any hesitation and a lot of clarity. So that was really good. And not many people are able to do that the way you did. So I thought that was really good. And then, yeah, then investigate bronch, laryngoscope, intubate the patient, and then sort out the other stuff like swelling. So, give dexamethasone as well, humidified oxygen, but re-bronch in ICU later. So that was good. In the ward the next night. Now, this is a horrendous situation. Have you been asked anything like this before?
I haven't specifically been asked about a kyko, but I have had a personal experience with one not that long ago. So
Oh, wow.
yeah, I've practiced the banter for that. But
Yeah.
no, I haven't been asked it in a viva specifically yet.
Yeah. So, and if you will, Andrew Hurd was probably the person that really revolutionized this with the the animal models and how do people actually react in these situations. And I'll put the link down to a lot of his stuff. He's got a YouTube channel that shows these. You described, so you chose the scalp. Like, first of all, you attended immediately. So again, really good things. This is life or death. This is terrible if it happened in real life. I can't imagine how much stress there would be for everyone involved, including the person who's in charge of the situation, which is you. You attended the patient, got them on speakerphone because you really have to speak to them directly to try and sort this situation out. But at the end of the day, you will not get there before this patient dies. So the best you can do is to instruct them, which is what you did. So I think you went through all the steps. You also vocalized your framework, the vortex model or, the DAS algorithm, whatever it is. You vocalized it so that, there's a shared mental model between you and the examiner, as well as potentially anyone else in the room who also knows those models. So that was really great. And you just proceeded along the pathway that you expected, knowing that I think you already knew that you're probably going to end up going to a CICO, and a horrible CICO because you're going to have to instruct someone in a CICO. So I think you progressed down that well. The one thing I would do in real life is, in CRM, I would probably do parallel management. So I would say, look, I'm going to talk you through this, get one of the nurses at the same time to get a Scalpel, Bougie, and a size 6 tube, which is available anywhere. You don't need, them to know what a difficult intubation trolley is. So that's the one extra thing I would say to do then in parallel, but you didn't waste time in the way you said stuff. So that's great. Why did you choose a Scalpel Bougie and not the needle crike technique?
The Scalpel Bougie technique is what is routinely recommended in our institution and across all of the hospitals across Auckland. Excellent. And it's the one I'm most familiar with and more trained in. We do get trained in the needle cricothyroidotomy as well, but you need more equipment for that. And Scalpel Bougie is, from what I've read, is faster and easier and has better success rates. So. Exactly.
Yeah. I tend to agree with that. So when Andrew Hurd first did his kind of studies on this, people were very, very hesitant with Scalpel techniques. So they thought that, anaesthetists use needles all the time, so why not use that as the first technique or the preferred technique? The culture has changed now. I think we train in these CICO situations so often that I do feel far more confident with the Scalpel Bougie because I train in it constantly, multiple times a year. So I think that I guess that resistance to Scalpel techniques may not be there in some people, definitely isn't there in me. I hope it isn't. Also, NAT4, do you remember what NAT4 said? Yeah, tell us about that.
So NAT4 was all about airway management. And
these are national audit projects, which the UK does amazingly well. They target a specific thing, and NAT4 was specifically on airways. Keep going.
Yeah. I'm trying to remember the specific thing. You mean just with regards to front of neck?
Yeah, that's right.
Yeah, so I'm trying to remember specific things, but I'm sure the success rates in Scalpel Bougie were more successful than...
That's right, I recall.
I can't remember the numbers.
100% with Scalpel techniques, whereas there's a higher failure rate with the needle techniques. And look, I run a lot of sims with this, and it is surprising how often the needle techniques fail for whatever reason in the wrong spot. They fall out, people don't hold it. There's just so many ways that these can fail, whereas Scalpel Bougie seems like there's just less parts to the whole procedure. When trainees do this viva with me and they do choose a needle crike technique, it is so much more difficult to say single step verbally to someone and to get all those steps correct that I've almost got this thing in my mind that, yep, in theatre, I've got all my CICO kit ready. Sure, I'm doing it with my hands. Fair enough. I may use needle crike. But if I'm outside of theatre, so I've got another algorithm for myself, which is outside of theatre or explaining to someone. So imagine I'm in PACU with some airway emergency, on the ward with an airway emergency, 3 pieces and far less movements and procedures is so much easier to do and explain. And so as an exam technique, but also in real life, I would do that every time, every day of the week. I'd do Scalpel Bougie instead of the needle crike in this situation.
Mm-hmm.
Excellent. Yeah, Rachel, that was really good. I'm really happy with how you went with that.
Thank you.
And not to give you too much confidence, but yeah, your structures, the way you flowed through, the pace of your speech, I've no worries with you. So honestly, I think you're doing really well, and then just keep it up.
Great, thank you. I hope you're right.
Yeah, too. Anything else you'd like to add, or?
Nah, I don't think so. Yeah, I've noticed, because I did your course, obviously a few weeks ago.
Yeah.
And I'm consciously, every time I do another viva, trying to work on a new bit of that technique. I kind of can't focus on doing all of it all at once, but I've tried to work hard on my opening statements and then, my planning for the anaesthetic statements. And I'm noticing just doing more and just picking up a new thing kind of every few vivas is definitely really helpful. So.
Oh, that's good. And so you found those patterns and the structures I was teaching in the Viva Bootcamp helpful? Yeah,
really helpful.
Yeah, I mean, for me, it was very new to me. I didn't understand that was what was required, or that was an easy way of expressing things in real life and in the Viva. So yeah, it's that's helping.
It is.
So let's call it that. Let's call it to a close. Thanks everyone for listening and watching. This is ABC's Anaesthesia. Please, share this with anyone who might be interested. And we'll tune again for another Viva or another interesting topic in the future. See you later. Thanks.